Okay, well, that was a very nice presentation, covering a lot. You know, there's two subsequent. My presentation is a little similar, the paranasal sinus neurovascular bundle. I kind of was watching, sometimes you don't know until you hear the previous presenter and maybe gloss over some of the things that have already been presented, so I'll fly through those and maybe touch on some clinical pearls that we have had, and giving maybe some short clinical correlations to this. And maybe you can apply this in the lab when you go back to dissect. So I think you already went through all the important vasculature, particularly of the nose. And you know that although most of the nasal vasculature comes from the external carotid artery through the sphenopalatine foramen, there is a portion that does come through the internal carotid artery, through the ophthalmic artery, and then of course giving off the branches to the anterior and posterior ethmoids. Some of you, as we were walking through the lab, were asking where these are. And again, this is an exercise that you need to, they're fairly easy to find. You just have to have the skill set to be able to find it and understand the anatomy. So the areas we want to focus on is the branches that come from the external carotid artery right here, but also branches that come from the internal carotid artery, and you should be able to find these in the lab fairly easily. So when we talk about the anterior and posterior ethmoids, here's a sagittal cut. You can see the maxillary sinus where the M is here with the crest of the antrostomy. I've circled the area that corresponds more or less where the anterior ethmoid air cells are under AE, which is across the horizontal portion of that antrostomy, and then the posterior ethmoids that are PE that are back more posteriorly where the transitional part of the transtrostomy is. And of course the arteries that go with these areas correspond with these areas. They're in the general roof of these areas. So when you talk about the last supramolar cell up here, the anterior ethmoid labyrinth, you're talking about the anterior ethmoid artery that's been marked in blue, and the same thing with the posterior ethmoid. And as Dr. Kamal mentioned yesterday, the posterior ethmoids generally lie in a bony canal most of the time. Probably the easiest way to find this one is to actually take the lamina prophysia off and then elevate the periorbital laterally and see as it goes into its canal. You can do the same thing for the anterior ethmoids, but these can be more variable. These can be in the membranous canal and easily injured during the course of surgery. You just have to be knowledgeable where they are, and if you do cut it, try to cut it medially, closer to the skull base, because that way it doesn't give it a chance to retract into the orbit and cause an orbital hematoma. Certainly easy to take care of. If it does bleed, you can just either bipolar or monopolar it. If you use a monopolar suction cautery, be careful not applying the tip of it to the bone around the artery, because as it chars, as you pull it off, you get a CSF leak. So when you're going to do that, kind of keep it off the artery and just let it coagulate. So if you look at the endoscopic view here you have the left side of the nose, and you see the remnant of the middle turbinate, the vertical lamella of the middle and superior turbinate, and the blue line circles, it delineates where the cribriform lies on the other side of that wall. Okay, and if you notice, you see the anterior ethmoid artery where the A is, and the posterior back here. Actually, there's a little middle ethmoid artery coming off the posterior ethmoid artery. You'll see some of that variation, not of any clinical significance. But note that where the arteries repenetrate intracranially medially, generally the anterior slopes anteriorly as it goes medially, okay? And it repenetrates around the anterior cribriform, It's the opposite with the posterior. It kind of slants posteriorly and re-enters intracranially with the posterior cribriform. So in between the two is the length of the cribriform plate, the olfactory bulb, all right? If you want to find this, take off some of this upper lamina prophysia, which is what you would do anyway if you were going to do a cauterization, for example, in combination with sphenopalatine, and then just elevate it as you see here in the lower figure, and try to see where it's entering the canal and identify it. Same thing with the posterior here. You can actually elevate the periorbital laterally, and you can see it. So try that in the laboratory when you're in there. So you already heard about the pterygomaxillary space. In general, and I came in a little late, The most common sphenopalatine foramen is type 1 that you see here, just a long oval opening. Sometimes you'll have it separated by a little fibrous bridge right here with the superior neurovascular bundle in the upper bigger one, and the inferior turbinate one and the smaller one and the inferior one. And sometimes it can be divided totally by bone. So the reason I put this is that if you have a posterior nosebleed and you're going to do a sphenopalatine cautery, make sure you go low enough to elevate the mucosa to isolate the potential existence of a separate opening. Because you can, for example, ligate or cauterize the lower one, but miss the bigger one that's above it. So make sure you get a wide opening. And what we're talking about is this bone here, the palatine bone, and particularly the front part of it, the orbital process of the palatine bone, because we're going to find that bone, find the pointer, which is otherwise known as the crista ethmoidalis, which points to the foramen, sphenopalatine foramen. And so when you elevate, this is just out of my book, these are based on real endoscopic pictures, and you can see here, this is the vertical crest of the introstomy right here. This is the insertion of the inferior turbinate. Actually, the inferior turbinate had been already removed, but normally the upper part of this is the vertical part of the introstomy. And then you can see there's two separate, there's a bigger opening. You can see the orbital process of the palatine bone right here. And you can see this pointer, and that pointer always points just behind it is the foramen, the sphenopalatine foramen. Okay, that's the crista ethmoidalis. And then below it, in this particular case, there's a separate artery, and you got to make sure you catch that, because sometimes you can miss it, to be bleeding from that. And then if you remove the bone from that vertical crest of the introstomy here, immediately, one of the reasons you do not do that during an introstomy and make it flush with the back wall of the maxillary is because of this little artery and nerve, the greater palatine nerve and the descending palatine artery that run right along that crest, okay, right below it. And that's what anesthetizes or innervates the soft palate posteriorly. So you got to be very careful, but you can certainly identify this artery. If you take the fat and the back wall off of the maxillary, and you can see the pterygoid muscles, you can see the branches that go to the infraorbital nerve, or the infraorbital nerve itself. You can see branches going to the pterygoid and the medial aspect of the temporalis muscle. You can see branches coming up and becoming the sphenopalatine and even the descending palatine artery. So I encourage you to do this in the lab and try to find these. You have to tease away the fat to be able to see that. And of course, the IMA is the main one that comes from below and goes vertically in the back wall, and of course branches into all of those structures. So as you saw before, if you go further back at the same level of the sphenopalatine foramen, you'll see the more rounder, not oval, but rounder Vidian nerve. And the Vidian nerve is actually just medial and not be confused with the palatovaginal canal, which is where the P is there. And of course, it's much bigger, and it's perpendicular to the foramen, the sphenopalatine foramen. So they lie like this with each other. And of course, all the parasympathetic fibers enter into the ganglion, as you saw in a very nice video previously, into the pterygomaxillary space medially, and of course it sends out fibers into the nose. There are procedures for vasomotor rhinitis where you can cut this endoscopically, or do a more partial neurectomy where we lift the mucosa off the palatine bone and just cut the partial Vidian neurectomy. Only the fibers are entering the nose, so as not to cause dryness of the eye. So there's some research looking at those procedures for some limited patients. This is just a sagittal view, again, looking at pterygomaxillary. These small arrows point to the back wall of the maxillary, and you can see where the foramen rotundum is. It's at the base of the pterygoid plate, up high laterally, whereas the Vidian is low. It's down at the floor of the sphenoid laterally. And as you saw, it leads to the carotid. I won't go into that, but generally this space becomes more narrow as you go inferiorly and wider as you go superiorly. And of course, laterally it communicates with the infratemporal fossa, as you've seen before. If you run into problems with bleeding, certainly in the clinic or the OR, this is an anterior artery that's we're just cauterizing with monopolar. Here's the frontal up in front, the supraorbital extension of a suprabular cell. If it's the sphenopalatine, same thing. These things stop with simple suction cautery. The internal maxillary is the same way if you're working into the back wall of the maxillary. As far as going deeper in this area, certainly you see the osteology of the sphenoid bone. I think the area that we're most concerned about, and if you do fellowships and you do advanced fellowships for skull-based surgery, one of the things you have to have is a lab with cadavers, and have, just like you have temporal bone labs, you have sphenoid bone labs, okay? And the sphenoid bone is what we drill. That's what the fellows practice drilling, because that's where all the important things are. It's easier to do an anterior skull base. There's nothing much there. But when you come to drilling around the carotid artery and see all the anatomy that you saw previously, it's important to understand the relationship of the clivus and all the different foramina of the sphenoid bone. This is just a posterior view looking at the foramen rotundum, and of course the foramen spinosum and the foramen ovale over here. And what we want to do is be able to drill this area, become familiar with the osteology and the vessels that come from that area. This is a front view, which is the more likely view we're going to see is endoscopically, where you're going to reach the foramen rotundum at the base of the pterygoid. You've got the Vidian canal, and of course the halovaginal with the rest of the pterygoid. And of course the lesser and greater ring of the sphenoid that determine where the superior and inferior orbital fissure are. And of course there are things that we do in that area as well. And of course, the osteology from below, they all run in a line. So if you start with the foramen rotundum and base of up here at the base of the pterygoid plate, if you go back posteriorly from that level and slightly lateral, you will run into the foramen ovale. The front wall of the foramen ovale is the base of the pterygoid plate. So if you take the pterygoid plate up to dura and go to the back wall where it ends, you reach the foramen ovale, as you saw again in the nice video that was shown. If you go into the if you take the pterygoid plate down, again you saw the foramen rotundum here. Sometimes you'll see in meningoceles of the lateral sphenoid, you have to drill this base of the pterygoid plate right here to be able to see laterally into the lateral recess. But you have to be careful you don't hit the nerve. And of course the arteries can be sacrificed, but you try not to hit the nerve at the foramen. Sometimes you can take this down completely and go trans-pterygoid back to see the foramen ovale and the foramen spinosum posteriorly. This is just an infratemporal fossa view. You can do a direct view by just removing where the asterisk is, which is the pterygoid plate. And this is what you get if you do that. You go into Meckel's cave, which Meckel's cave is where the trigeminal ganglion sits, and you see the the first, second, and third division of the nerve. It is an arachnoid area, so there's a CSF leak if you reach that area. The front wall of this this bone that you see between V2 and V3, this is all the base of the pterygoid plate. So when you're coming from below and you remove the pterygoid plate, you will be seeing these structures. And this is just a nice view of that area, looking at the various nerves. You go to V3, V2, and so forth, where the base of the pterygoid plate has been removed, and you see the entire extent of the different portions of the carotid artery. The chordomas and all that, it's important clinically to understand this, because that's where you might find small structures like this. This is a chondroma in the pterygomaxillary infratemporal fossa, easy to take care of, transeminent maxillary. But then you get into other situations where it's more typical of an angiofibroma like this, where of course with embolization you can confirm, and then you go ahead and resect these type of tumors, and you have to be very cognizant of the anatomy of this area. Yeah, I got it. 2 minutes actually. And so there are other lesions back in that area, including lesions of V3 here, where you go trans-pterygoid to approach that area. And biopsy in this case ended up being a small schwannoma. And again, you can get cancers in that area. You want to take it back to the foramen ovale. You have to be very cognizant of where it lies, Navigation is extremely important here. And then finally, there's the posterior aspects of the carotid artery. You've already seen a lot of that. This area we'll cover later when we talk about the clival, paraclival area, but you have to understand the different portions of the carotid. In the case of the clivus, we're talking about the paraclival area, which are these two columns that we see on each side of the sella, and it's in that area where we might see petrous apex cholesterol granulomas and certain chordomas and so forth. And when we take that bone off, certainly this is something you can do in the lab as well. You drill that bone off, you show the cavernous with the sixth nerve, which is, you saw previously, was the first one. And again, this is a nice exercise to do if you have a little time in the lab. And then of course, this is just the same thing. So with that said, don't forget that there's also a venous anatomy around this area. And there is, and it's from here where you're actually more likely to get bleeding. This is all the venous plexus, the paracavernous, cavernous plexus. Actually, that's the easy thing to take care of. A different topic for discussion on how we do it, but it's certainly something to be aware of. And then later on, we'll talk about the paraclival area with the basilar artery and everything that's behind if you want to take the clivus down, you'll see that. If there's anywhere where navigation is extremely important is when you work around the carotid. So if you're anything I've talked about now, from the posterior and middle cranial fossa, we don't use navigators that much for the anterior skull base. We don't use it that much for chronic inflammatory disease of the sinuses. Not even Lothrop's we use it, but we do use it back here. And we use fusion. And we want to know where the carotid is. We'll even use Dopplers because we are drilling around the carotid artery. Thank you.